Bon dia a tutto. I'm really happy to be in Campinas with this very active Gruppo do Joelho, and I was really impressed yesterday by all the power you put in the education of the young surgeons, and it's a great thing. And your meeting is also very well known in France, and especially in Lyon. And I'm proud to be here, and thank you, Wilson Mello, for your invitation. I will start speaking about ACL and a study we did comparing three types of ACL plasty. It's a clinical and a radiological results, 2 years follow-up, and you've seen that there are many Brazilians who work on this study too. The ACL surgeon is probably double bundle or mono bundle. And when you are going to different knee meetings, you will be really impressed by the number of publications comparing or trusting double bundle or mono bundle. But maybe the question is a little bit different. And from my experience, I would say that the question would be more if you have to do an isolated graft, and which graft is probably the best to use to your patient, and especially to your patient. So we did a study, and we took in 2005 on 196 ACL graft. We took 25 randomized patients in this series. The first technique was BTB, outside in technique. It's a technique we use in Lyon for many years, using the BTB with a press fit system on the femoral side and an interference screw on the tibial side. This technique allowed us to position it in a really anatomic position, and also to keep the remnant in the knee if you still have some ACL in the knee. The arrival of the tunnel is just above the LCL, and we usually have an orientation of 30 degrees anterior-posterior, and this would allow us to be really posterior with no blowout for sure. Then the graft is passed. This is something sometimes a little bit difficult, so you have to have a very good preparation of your graft if you want to be easy to do this surgery. The second technique was a double bundle hamstring using 3 tunnels. It's a technique I described in 2004 in the French Arthroscopy Society. I harvest gracilis and some IT. Put them in a 1 strand, and then we will drill 2 tunnels on the AM position and PL position, and then 1 tunnel in the footprint. And then the graft is passed from the tibial side to the PL tunnel. Then it makes a loop and goes back in the AM tunnel to be again in the tibial side, and then we are able to fix it with 1 screw, and it's a quite economic issue because we use only 1 screw for a double tunnel technique. So you see the graft is going out from the PL port tunnel. We cycle the knee, and then it will go back in the AM tunnel, and it's really easy and simple to do. And then we fix it with a screw after cycling. So on the femoral side, we drill 2 tunnels of 6 mm outside in technique, of course. We use anatomic landmarks if we still have some ACL remnant in the femur. And if we don't have any anatomic landmarks, we will position our guide 5 millimeters down and 5 millimeters anterior. And for the tibial part, we use the stump of ACL. We keep it We try to preserve it all the time to keep mechanical receptor vascularization, and we push the screw up to the tibial plateau. And you see this is the PL going up, and then the AM will goes back from the AM tunnel to the tibial side. Easy to do, really easy to do, and simple. The third technique was the BTB plus an extraarticular using the Lemaire technique. Lemaire's technique used to be done with the fascia lata, going below the LCL, then in a bone tunnel on the femoral side, then going back below the LCL and in the jersey with a bone tunnel. This is a very efficient surgery for controlling the rotational instability and to prevent any pivot shift. But it has no influence on the AP translation, so that's why Henri Dejour combined the two techniques to control AP translation and pivot shift. We modify a little bit the technique using a free gracilis and not using the fascia lata, so we are able to do very small scar incision, but the technique is the same, going below the LCL and going back in the jersey. So we did this comparative results between these three procedures. We took 25 patients each group, and the inclusion criteria were these one. You will see that the three populations are a little bit different in terms of laxity. The BTB plus Lemaire was had a higher laxity. They were also younger, and they were also more active. We indicate that, of course, for high-grade laxity. The other thing is that in this population, we had more medial meniscectomy in the double bundle population because they were a little bit older than the other one, and in the BTB plus Lemaire we had more meniscus suture, of course, because they were probably younger. The clinical analysis was done by an independent observer, Wilson Vasconcelos, and he used all those forms to make the analysis. And the things which was really important is to quantify the laxity of the patient, and we use the Telos X-rays with 15 kilograms of pressure, and we measure the medial compartment translation, the lateral compartment translation, to understand if there were any rotation and how we were controlling the AP translation, medial and lateral. So we look at the anterior knee pain, the results to sports level, and the ability to kneel between the three populations. And you can see that probably the BTB plus Lemaire technique had a less return to sports activity, a little bit less than the other group. We also saw that the double bundle hamstring technique had a better ability to kneel, and they were less painful while kneeling. But if you look to the statistic, there will be no differences for the anterior knee pain and sports return, but only a better kneeling in the double bundle hamstring group. About the sensibility deficit, it's also something important when you evaluate your patient, your ACL patient, is to touch the skin and ask them if they are painful or not, if they can feel your finger when you touch the skin. And you will see that on the BTB group, monobundle or BTB plus Lemaire, they had more complaint about the sensitivity, and they had more hypoesthesia in this in those groups. So for sure that the hamstring group double bundle was better for that things. About the ICADC, objective ICADC, comparing the three groups, we had no differences, no statistical differences. So we were a little bit disappointed about that. And about the global ICADC, what you can see is that the scores are about the same, but you will see that on the BTB plus Lemaire, the scores were a little bit less good than on the two other groups, but the statistics said no difference. So what can we say about this? Maybe if we go a little bit further in the populations we have, we will see that on the BTB plus extraarticuloplasty, we had a little bit more lack of extension, so the patient did not get back to the full hyperextension, and this could be a problem in a very high sports level patient. They had a little bit more lack of flexion, and they had more swelling knee. Maybe it was because it was a higher laxity, but this could be this could explain the different results, and we could maybe say that the BTB plus Lemaire was maybe a little bit too tight. And it's probably not a very good thing for high-level sports guys. So looking to the objective results now about the anterior tibial translation on the medial compartment,